Let me thank the organizing committee, Allah and Dr. Musa, for the invitation. This will be true aorto coronary dissection, but is not related to, is not iatrogenic, and it's not CTO case. This is a 77-year-old man with coronary artery disease who has multiple intervention on the right coronary artery, and they stent, and they said it's restenosis and restented, and he presented to another hospital with some chest pain, mild T-wave changes, no ST changes, and mild elevation in his troponin, and he was cast in this hospital, another hospital, and you see this is the area. Is there any? Anyway, but you see there is this stent area, and there is some haziness. So the doctor there did ballooning to the area and upgraded the balloon size, and did well, and this is the final angiogram. But he did call me and said if I can do anything like IVL for him. And also the patient did read something about brachytherapy because he told him this is instant restenosis. So anyway, I brought the patient only about 3 weeks after this cath lab, and I did use AL from the right radial. And this is the angiogram, and you see the lesion here. So I tried to do IVUS in order to see what's the pathogenesis for this lesion. So the IVUS did not cross, so I had to dilate the area with NC balloon until I got the IVUS. And this is, and I'll show you the IVUS, but I get the minimum lumen area of 1.76. That's too tight. But this is the IVUS. Anyway, we'll go from distal to proximal. And here we are coming back, and now we'll enter. This is still normal lumen, and then there's the stent. You see the stent, and probably now you see 2 layers of stent, but it's well opposed, and I don't see any new intimate proliferation. And then we'll go more to the lesion. And this is the area, and you see now at least there is 3 layers of stent. I hope that you can see that, 3 layers of stent, and it is too tight. So there is no new intimate proliferation. So I don't think brachytherapy will help. I think the stent to start with was underexpanded because of calcified lesion, and they could not open the stent well. So no brachytherapy. So I did use the lithotripsy, and this is the lesion, and did the IVL. And again, the IVUS showed now the minimum lumen area came up to 3. So still, we have to do more. So I did use the NC balloon, the area, and upsize from 3.375, and then use a shorter balloon, hopefully, because we can inflate more and dilate just this focal area. And again, I've reached the minimum lumen area of 3.82. So can we do more, or shall we stop? Sorry? Stop. With this, you'll accept this?
No, he's sitting there. That's why he's sitting there and saying stop.
Okay.
But you aren't.
Okay. So what I'm sure everybody knows about the open NC balloon. So the high pressure. And this is the one. And I used that. And you see that here. And this is the cine for that. Okay. So what happened? The patient did get severe chest pain, and I noticed when I reached only about 30, only 30 on this. The patient did complain of chest pain, and sorry? It's 4. Oh, yeah. So I noticed on the indeflator that the pressure dropped. So I thought that this is rupture balloon, and the patient did complain of chest pain. So with that, everybody thinking about this is a perforation. So in order not to do this, so I said, let's get a puff. It's not injection, it's just a puff, and this is the puff.
Okay, great.
So this is aortocoronary dissection. This is the true case of aortocoronary dissection. So now, what? Okay, now I have the wire. And so I stopped doing any injection. So the patient is, okay, so, but everybody in the cath lab, no. Stop. So anyway, so what's the next step? So since the patient was continued to have chest pain, but his hemodynamic is reasonable, he did not drop his blood pressure. This is classification of Bill O'Neill when he was at Beaumont Hospital with and fiber. So it's almost the classification that was mentioned. So we're not going to go with that. But the main point is to assess the patient whether stable or unstable, avoid any further injection. If you want to do distal injection, use the IVUS and stent the coronary with a DES or cover stent and assess the progression with TEE or CT, and then consideration for surgery. So since I was doing every step with IVUS, so this is the IVUS, and just this is now proximal to the stent, and you see that there is some area of dissection. I hope you got it, but anyway, if you don't get it now, I'm in the guiding catheter. The fixed picture. That here on the low at 6 o'clock, there's 2 layers here, and this is another view. So this is a dissection. So just without changing anything, without changing the guide, the wire is still there, no injection, just pulling the guide a little bit, put a stent, and in order to make sure that we are stenting the ostium, so I put an extra wire. You see the wire that's to assess where the cusp and where is the ostium, because there is a distance now due to the dissection between the ostium and what you think it's the RCA. So this is the way, and I stented that. With this, I used this is a cover stent. So anyway, and did post-dilation for this cover stent. And even that, I tried with another balloon in the lesion, and I did not get any more extension. And did the IVUS to the lesion. Now I have 4.9 square centimeter. And this is the final angiogram. So the patient now is stable, and you see no filling. But what to do next? So now the patient was stable, and I'll tell you, moved to the ICU, and I'll tell you what I did later. But I tried to find the mechanism. What happened here? There is no iatrogenic. There is nothing, and there is no perforation, and was going step by step. So I went to the balloon. I went to the trash and got this balloon. And this is what happened. And I tried to inflate the balloon. And what you see here, that the leakage of the the balloon is inflating with the leakage. Where is that laser point? Okay. The balloon. So this is a shaft rupture and barotrauma at the shaft that caused this dissection in the aorta. And so this is not a balloon rupture. I'm sure everybody agrees. This is a shaft rupture, and this is not a balloon rupture. So this is a rare mechanism for developing aorta. So the next step to do CT or TE or surgery, the patient was stable, so I did not consider surgery at all. But this is the CT, and you see that we have the dissection, and here, and extending is more than 40 millimeters. So I have to write to Bill O'Neill, tell him that I have a case more than 40 millimeters. So this is also the for contrast. dissection. Just give me 30 seconds. It's only just 2 pictures. Just. Okay. And this is the diameter. I monitored the patient and repeated within 24 hours, and it is getting less and less, and the diameter is back to normal. And we followed the patient and brought him 3 months later, nothing there, and he's still asking what we can do for his RCA, and still insisting, do brachytherapy for me. Okay, so this is the take-home messages. When you use high-pressure balloon, try to find what's causing this, and don't inject, and everybody knows about that. Assess the entry point, and use the IVUS if the patient is stable to assess the mechanism.
Excellent. Thank you very much. Again, Dr. Walid.